Talk on Pulsus Paradoxus, structured in a way that is informative, engaging and clinically relevant. So, understanding Pulsus Paradoxus. It is a clinically and pathophysiological insight. So, I am going to discuss an important yet often underappreciated clinical sign, Pulsus Paradoxus. This is not a paradox in the literal sense, but a significant hemodynamic phenomena that can provide critical diagnostic clue in several life-threatening conditions. So, definition and mechanism. Pulsus paradoxus, that is PP, is an exaggerated decrease in systolic blood pressure SBP by more than 10 Hg during inspiration. Normally during inspiration, venous return increases, leading to a slight drop in systolic blood pressure due to ventricular interdependence. However, in conditions like cardiac tamponade, the pericardial pressure is elevated, impairing ventricular filling, leading to a pronounced inspiration systolic blood pressure drop. So, pathophysiology. To understand this phenomena, let's briefly discuss ventricular interdependence. During inspiration, negative intrathoracic pressure increases. Venous return to the right ventricle RV, causing it to expand. In a normal heart, the septum accommodates this without affecting the left ventricular. However, in cardiac tamponade, the pericardium is stiff and the right ventricular cannot expand outward. Instead, it shifts the intraventricular septum toward left ventricle, reducing the left ventricular filling and thus the cardiac output. Means this results in a significant fall in systolic blood pressure beyond the normal physiological range, more than 10 mmHg, which we detect as pulsus paradoxus. Common cause of pulsus paradoxus are: pulsus paradoxus is an important bedside sign in several conditions, particularly 1. Cardiac tamponade, the most classical and critical cause. Second, constrictive pericarditis, though less common, it can mimic tamponade physiology. Third, severe asthma and COPD due to exaggerated intrathoracic pressure changes. Fourth is a tension pneumothorax. leading to impaired venous return. Fifth is a massive pulmonary embolism. It can cause right ventricular strain and paradoxical septal motion. Sixth is a hypovolemic shock. Can sometimes present with pulsus paradoxus due to reduced cardiac output. Clinical measurement and significance. How do we measure pulsus paradoxus? 1. Manual blood pressure measurement. Inflate BP cup, that is a blood pressure cup, above systolic blood pressure and deflate slowly. Note the first corophoc sound heard only during expiration and the point where it is heard in both inspiration and expiration. The difference between these two values is the pulsus paradoxus value. Should be less than 10 mm in normal individual. Pulse, second is a pulse oximeter or arterial line. Arterial waveform can show exaggerated variation with the respiratory cycle. Clinical implication. Pulsus paradoxus more than 10 mm of mercury should prompt suspicion of cardiac tamponade. In asthmatic and or COPD patient, a very high pulsus paradoxus suggests impeding respiratory failure. In hypovolemic patient, detecting pulsus paradoxus can help in early bedside recognition of pericardial tamponade of massive pulmonary embolism. So, to conclude and to summarize, pulsus paradoxus is a vital clinical sign that reflects abnormal ventricular interaction. It is commonly seen in cardiac tamponade, constrictive pericarditis, severe asthma, and tension pneumothorax. Detecting and interpreting pulsus paradoxus can provide crucial early diagnosis clues aiding in timely intervention. Thank you.